Good afternoon, dear participant, and welcome to the HIV/AIDS National Distance Learning Seminar Series. Today's topic is Basic Chest Radiology for TB Diagnosis in People Living with HIV. Today's speaker is Dr. Anwar Pervez Syed. Dr. Anwar Pervez Syed served as a medical advisor for the International Training and Education Center for Health India. In this role, he provides technical assistance to NACO and its Center of Excellence for carrying out various technical and programmatic activities. Dr. Anwar is a chest physician and a fellow of GHTM ITech HIV Fellowship Program 2007 batch. He served National AIDS Control Organization as a regional coordinator, care support and treatment for the states of Maharashtra and Goa for 2 years. He also served the Indian Red Cross Society's Bel Air Hospital, Panchgani, Maharashtra, in the capacity of consultant HIV TB physician and capacity building specialist for 3 years. Thank you so much for accepting NDLS invitation, Dr. Anwar. Please take over the session.
Thank you, Dr. Vinita. A very good afternoon to all of you, and welcome again for this National Distance Learning Seminar Series session. So today's topic is basic chest radiography or radiology for TB diagnosis in PLHIV. So I understand this is a very important tool. Chest radiograph is a very important tool at our ART centers. Some of the centers where there are no advanced facilities available in radiography itself, and where chest X-ray becomes really important as a supportive tool to diagnose the opportunistic infections and TB and other things in PLHIV who attend ART clinics. So that was the main purpose of having this session here. So considering the various experience and the level of knowledge our participants have, some of them will be radiologists and some of them will be new to the ART centers. So we have tried to maintain a balance between two extremes of knowledge and skill pool in interpreting chest X-rays, and that is how we have planned this session in terms of basic chest X-ray reading, and then we will be going through some of the slides, and in which in the basic chest X-ray reading we will be trying to focus on the chest X-ray anatomy of the posterior anterior view and lateral views. We'll be also talking about the technical quality of chest X-rays and what should be acceptable to the ART medical advisors if they are reporting a chest X-ray, and when we can repeat the chest X-ray so that accurate diagnosis can be made, or at least we do not miss the common findings. We will also try to discuss and recognize the radiographic patterns of the disease and describe using appropriate terminology for them, and that means how to report a chest X-ray basically, and both typical and atypical presentation or patterns of radiographic presentation of pulmonary tuberculosis. Now, before moving ahead, I'll just mention that though radiology will include CT scan, like high resolution CT scan and other things, but I've tried to focus on chest X-ray only for the sake of the time and the importance and availability at most of our ART centers, so that and itself it will take an hour or so. So maybe if time permits we can have the sessions on other tools later on, but for this particular session we'll be focusing basically on chest radiographs and how to read a chest X-ray in context of tuberculosis, and how to interpret chest X-ray findings in terms of more appropriate terminologies which are standard ones. So this will be the overall view or overview of this presentation. We will try to discuss the natural cause of TB and risk of TB in HIV. These two things will be really important in understanding why certain findings will appear in certain parts of the chest X-ray. So if we understand the natural course of TB disease, it is easier to interpret chest X-ray and also to predict some of the findings, because a person, if knows the natural course of the disease and can compare that finding to the level of immune system, or what is the CD4 count and other things, and basically with that you can interpret the findings. So it is worthwhile to spend few minutes on natural course of TB disease, though it is not directly related to today's topic. But today's topic will be based on those slides. Then manifestation of TB in relation to HIV immunosuppressions. We all know that there are certain differences in presentation of tuberculosis in an immunocompetent and immunosuppressed host. So we'll see how the manifestations they differ. We'll be again focusing on chest X-ray features. Then relevance of X-ray itself or X-ray chest itself in this scenario. That will cover a few aspects of how it is relevant, and how much should we rely only on chest X-rays. So we'll focus on that point. Then we will try to cover some of the aspects like systemic approach to reading a chest X-ray, then basic X-ray anatomy, and then patterns of disease, radiographic manifestation of TB, and there are some slides towards the end which will be the case studies, and I hope you will be interested in going through those case studies, so that there would be some hands-on or some practice of just interpreting a chest X-ray. So this session will be a bit interactive, so I'll request all of you to whenever I display a chest X-ray, so I'll request the medical officers to give their opinion on the chest X-ray, so that it will be good if you can make it an interactive session. This is a very basic fact about tuberculosis or natural history of tuberculosis. I hope the people, I understand that this session is being attended by medical officers and also other staff of ART centers. But at least for ART medical officers and staff nurses, you might have learned in the basic graduation that when we talk about movements of chest, there are two kinds of movements those happen. One is called as pump handle motion or pump handle movement, and second is bucket handle movement. These two are nothing but to increase the transverse and vertical diameters of the chest, so that the air gets sucked in, or we inhale, and then automatically when diaphragm relaxes, automatically the exhalation of air happens. So why I'm mentioning this point here is because some of you might have this question that why are TB bacillus, when we talk about day 1 of infection, it gets lodges in upper part of the right middle lobe. So this is one reason is this is the area where the aeration will be more, because again this is more in line, the right bronchus is more in line with the trachea, and that is why when a person inhales, the bacillus will come in and get itself lodged in the upper part of the middle lobe. So that is day 1 of the infection. Usually it happens in the childhood, and it leads to development of primary tuberculosis. So there are few terms which are very basic and which are used to describe tuberculosis in the natural course. Now one is primary tuberculosis, where it is called as Gons focus, and when the TB bacillus is here, to remove that TB bacillus, the other machineries they come into play, and the lymphatics and then the regional lymph nodes, that is hilar lymph nodes, they will get enlarged, and along with this, that is this Gons focus, lymphatics, and the hilar lymph nodes, this is called as Gons complex, which happens in 2nd to 3rd week of the infection. Now there can be various fates of this Gons focus. One is either it can get resolved by itself, or it can get disseminated, which is called as hematogenous dissemination, where tuberculin test becomes reactive. What it means is, while as a next step to this infection, this enters into the bloodstream through the blood arterial supply of this or venous supply of this organ or lung, and through that bloodstream there will be dissemination, which is called as primary dissemination, which causes hematogenous spread of TB bacilli everywhere into the body, including lung itself. And that is the reason how it reaches in the apex of the lung and other places, like all organs, and wherever blood goes, it will take the TB bacillus with it, and that happens within 4th to 5th week of infection. And once that is settled in, the body's immunity gets activated, and many things happens. I don't want to go into all those details, but what happens is either the bacillus, which is lodged in the apex, where the oxygenation will be higher as compared to the lower part of the lung, where the blood supply will be higher, and that is the reason the growth of or multiplication of the TB bacillus will be more at the apices. So fate of these bacilli can be either the growth itself gets arrested, or these bacilli can be killed, or they will become dormant bacilli. Dormant bacilli are those who will reside there for years and years together, but they will not grow unless there is a favorable conditions like immune suppression, like any other thing, where they will further multiply and they will be a reason for the disease. Usually it happens within 1 to 2 years. So highest risk of developing TB disease from infection will be within first 2 years of life, after first 2 years after a person acquires TB infection. So when it is here, then it is called as Simon focus. So this will be a dormant bacilli, so it will wait for the appropriate time, and when it gets any favorable conditions, it will develop itself, and then it is called as reactivation of tuberculosis, and where again it can be regional lymph node or hilar lymph node can be involved, and here it will be get resolved. So, and that is because failure to contain organism within macrophages. So that is the reason we see most of the TB X-rays in an immunocompetent person. You will see the lesions in the apices or apex of the lung. Okay, so this happens as a and after this, what can happen is from the lymph nodes or through these lesions, when there is formation of cavities in immunocompetent person, if bacillary load or the caseous material which has the bacillus, if it enters the bloodstream, then it will cause a secondary dissemination, where you will see the TB in form of miliary TB and other forms of systemic tuberculosis, and that can happen as a after reactivation, which is called a secondary dissemination. Remember, this was the primary dissemination, and here this was the secondary dissemination. Just to reiterate these things further, after a person gets primary infection, it will be infection of the lung. Usually it happens in the childhood, and a person will be asymptomatic most of the times. And that is the reason, even though we have TB infections, all of us do not present with TB symptoms even at the childhood, when we had acquired the TB infection. Now, fate of this primary tuberculosis, 90% of the times, either it can get calcified by itself, forming a granuloma there, or it can remain as a latent tuberculosis or latent infection. Latent infection means bacillus will be there, but it won't cause disease at that moment. So person will be infected with TB. Like you know that 40% of India's population is infected with tuberculosis. Or the fate of primary tuberculosis can be either it gets converted into progressive primary infection. That means you have a primary infection, and then it has further spreaded into the vicinity of itself, and also may get dissemination as primary dissemination. So this is called as progressive infection. Usually happens in immunocompromised person. Please remember that immunocompromised persons or people, they will behave like a kind of primary tuberculosis which happens in the childhood, where they don't have immunity intact, and whenever they have infection, and from the middle lobe, it can get disseminated as a primary tuberculosis. So it can be a progressive primary tuberculosis, or 5% of the people will have post-primary tuberculosis, which is nothing but years after primary infection, a bacilli which was dormant in adulthood, it will get reactivated, or there can be a reinfection. So in short, a person who is infected with tuberculosis will have lifetime risk of development of TB 10%, and 90% of the times he or she will not develop tuberculosis. But the problem is in HIV, this risk, I'm sorry, I don't know why I'm not getting this graph, but the I'll just let, okay, one second. I'm not able to see this graph. Okay, but this graph was basically, here there was one bar showing 10% and here there was one bar showing 60%, and that means the risk, lifetime risk of development of tuberculosis, it increases from 10% to 60% in the people, or 50 to 60% in the people who are HIV infected. So, and this can happen because of either relapse or reactivation, or it can happen because of the reinfection. People have even done that genotyping also to see whether it is only because of relapse or it is because of reinfection. So that is the reason, if we have tuberculosis, or if someone has tuberculosis in the later part of HIV infection, the risk of mortality is really higher. If we look at the percentage of people who are HIV, estimated burden of HIV among TB patient is about 5%. So take home from this slide, which is actually, it is a NACO slide, you might have seen this slide during trainings also. So risk, lifetime risk of development of TB, which is 10% in general population, increases to 50 to 60% in people living with HIV. This is the algorithm. Now we come to the X-ray part. Now in the diagnosis of tuberculosis, X-ray they play a really important role. If you compare this algorithm with diagnosis in non-HIV or HIV negative person, where we rely more on the sputum and other things, and here also please remember that it is not dependent on X-ray, but it is an X-ray will be a supportive tool for diagnosis of TB even in people living with HIV. But the difference is, here we go for chest X-ray in the very beginning of the algorithm for diagnosis of TB in such patients, where whenever we see a TB suspect, we go for 2 sputum smear. Along with that, we do chest radiography, and then based on the findings, we will further consider whether patient or person is having TB disease or not, and then whether require TB treatment or not. But the point I wanted to make from this slide is X-ray has made its place in further initial part of the algorithm of TB diagnosis in people with who are living with HIV, in comparison to those who are HIV negative, where we do chest X-ray only if there are 2 sputum negative, and then after that you give an antibiotic course, and then if a person still has symptom, then we'll do repeat sputum, and if repeat sputum is negative, then we go for chest X-ray. But that is not the case with HIV positives, where we do chest X-ray in the very beginning. But there is a problem again. This is actually just to show the difference between or manifestation of tuberculosis in early phase of immune suppression versus late phase of immune suppression. In the early phase, we will see all findings of TB similar to any other immunocompetent person, and in the late phase, we will see findings similar to primary tuberculosis, that is atypical presentation. Often infiltrations we will see, but less of the cavities, because you all know that for formation of cavity you require an immune system. Cavity is nothing but response of immune system. How it happens is, like we saw in the previous slide, in the course of the disease, when these granulomas they come together, they form coalition of the granulomas, and then there will be a central liquefaction. Are you with me in this? There will be a granuloma, there will be central liquefaction, and when this central liquefaction, which contains high number of TB bacilli, when it comes into contact with the bronchus, then it will be emptied into the bronchus, and then that's how the sputum will contain the TB bacilli. And the remaining space will get filled with air and it will form the cavity, and then it will be more oxygenation and will be most favorable environment for the TB bacilli to be present there. So for all this to happen, you require an intact immunity that will be there in the early phase of immune suppression. But in the late phase of immune suppression, there will be atypical presentation of an infiltration, mild, mid and lower lung field lesions like in primary TB, and then intrathoracic lymph nodes and infrequent cavities also can be seen depending on again level of immune suppression. Again, this slide has been taken from NACO training modules. But can we rely on X-ray completely? This is one of the studies which was published in Journal of Acquired Immunodeficiency Syndrome in 2013, and all stalwarts in TB management like Tuberculosis Research Center, Chennai, and Government Hospital of Thoracic Medicine, Tambram, Chennai, and National AIDS Research Institute. So all involved in this study, and they tried to evaluate the utility of initial chest X-ray in diagnostic algorithm for symptomatic HIV infected patients with negative sputum smears. That means those who had sputum smear negative, they saw whether X-rays will help in diagnosis or of TB or not. And what they found was this X-ray had a sensitivity and specificity of 72 and 57%, with positive predictive value of 21% and negative predictive value of 93% to diagnose PTB. And that means you cannot completely rely only on chest X-ray to make a particular diagnosis of tuberculosis, though it is moderately sensitive, but basing a diagnosis of TB on the initial chest X-ray, it will lead to overdiagnosis. So this is a point of caution we need to keep in mind before moving ahead in terms of chest X-rays. Let's come to the point. This type of or chest radiograph is the cornerstone for the diagnosing and evaluation of respiratory symptoms in HIV infected patients, and that is the reason we do it in very early stage of algorithm, not in very late stage or not in the later part. So chest may have many types of opportunistic infections and also neoplasms, and X-ray will have some of them will have very typical findings on the chest X-ray, but they are not very definite of that that condition unless it is supported by other modes of investigations like biopsy and then microscopy or clinical examination, history taking. All those things will become really important, and that is the reason I think all radiologists, they will write one line below their findings, please correlate clinically. So that itself means that no finding will be definite of a condition. There can be multiple differential diagnosis. So it is just a supportive tool to make a diagnosis along with history, clinical findings, and other lab parameters need to be checked before labeling something as a that particular condition. So this is just a supportive tool. Oops, sorry. So these are nothing but photon rays which are absorbed, scattered and transmitted based on or depending on the material through which these are passing. There are two things which decide its absorption. One is beam energy, which will be constant, that is machine will be set to a particular beam energy, and other thing is tissue density through which these things are passing. Now we need to remember or various densities, so that then findings can be could be understood. Then this is maximum chest X-ray transmission will happen through least dense tissue, and and obviously the least dense tissue will be air. That means air will look black, and the maximum, sorry, this is maximum absorption and this is minimum absorption. I'm sorry for that typo error. So and the maximum absorption will be metal, will be whitest part, and all the other things like from air, then fat, then soft tissue, then calcium, then bone, then contrast, and then metal, this will form in that range. So air will look black, fluid will look white. Please remember this in this series of various absorption capacity of chest X-rays, and so that it will be easier to understand the findings then. But why we see what we see? The structures are visible on chest radiograph because of juxtaposition or of two different densities, that like closeness of two different densities. For example, you have diaphragm here, right? So this is looking white, right? And just after that you will are seeing this black area, which is nothing but air. So the line we see here, because these two are now close to each other. But if something comes in between, then all these lines, they will disappear and you will not be able to demarcate these structures. So this, if you are not able to demarcate certain line which is expected to be there on chest X-ray, then it is called a Silhouette line or Silhouette sign. That is loss of expected interface. That is, no boundary can be seen between two surfaces because they are now similar in density, right? So if we see this X-ray, just an enlarged view of the previous one, this is called a Silhouette sign. Where can anyone tell me where we see a positive finding in this chest X-ray? Parahilar. Okay, we will come to hilum after a few slides. Right lower lobe. Okay, I'll please remember this point also about lobe. Right lower zone capacity. So thank you for mentioning all those terminologies, because they will mean a lot. I will be very soon addressing those, which will be should be called as lobe, and then zone, and then about hilum, all those. But exactly as you rightly pointed out, here is a problem. Here you are seeing a patch which is obliterating this diaphragmatic border, and then that is how it is a Silhouette sign, which is positive because of consolidation. So we'll come to all these details in future slides. Thanks for your response. ART Center Surat is not able to listen to me, or there is some voice problem, I think. Is it okay with other centers? Okay, so this is an X-ray and picture of right lung and left lung. We all know in the basic anatomy of lung, we have 3 lobes on the right side and 2 lobes on the left side, which is not always necessary. It can be three on both sides, and other like 2 on left and 3 on right, or the reverse way also it is possible. But usually this is the scenario. Right side you have 3 lobes, and left side you will have 2 lobes, upper lobe and lower lobe, upper lobe, middle lobe and lower lobe, right? And if I can further break it down into the segments, right lung will have 10 segments and left lung also will have 8 to 10 segments. So there are various names of these segments. I will not go in those details because it may confuse few people here. So when we see anatomy of lung, these lobes are divided by fissures. So on the right side, upper and middle lobe is divided by a transverse fissure, and there is an oblique fissure which divides middle lobe from the lower lobe. On the left side, there is only an oblique fissure which will divide upper lobe and lower lobe. So if we see a bit in detail, the same thing, right lung on lobes and fissure, but here you will appreciate that you will see an overlap here, right? Ideally what you should be seeing, as per most of the people I have seen, they interpret chest X-ray in terms of lobes, upper lobe, middle lobe and lower lobe. So this is not like there are 2 lines here, 3 parts, upper part, middle part and lower part, that is upper lobe, middle and lobe. No, it is not like that. So you will see a clear overlap here, right upper lobe and right lower lobe. So where is the right middle lobe here? So to see right middle lobe, it will be here somewhere. If you want to see on the chest X-ray, it will be somewhere here, and which can be seen in a better way, which is between minor fissure, that is transverse fissure, and horizontal fissure, and this is the lateral X-ray of the right side. Okay, and here you can see the right middle. It is not exactly like three divisions on the lung to see upper lobe, middle lobe, and lower lobe, but those will be called as zones. I'll come to those things later, but please remember here that you do not see all three lobes in three parts of the right lung and two lobes on two parts of the left lung on the chest X-ray. So there will be an overlap of lobes. You can better appreciate that into the lateral view of the chest X-ray. For the beginners, just I'll mention that whenever you see an X-ray, please, some people, they get confused between right and left also. So just imagine as if a person is standing in front of you. So his right will be right side of the X-ray, his left will be left side of the X-ray, and that is the reason this is the right side and this is the left side. And similarly here you can see, and here you can see this is the right lateral view of the chest X-ray. Similarly, if we focus on the left side or left lung, now this is left upper lobe, which you will see like overall image of the left side of the chest X-ray. That is left upper lobe, right? And left lower lobe will be somewhat up till here, but it can be better appreciated in, again, lateral view, where you will see below the fissure is left lower lobe, above the fissure is left upper lobe. So I hope you can appreciate here that you cannot report chest X-ray unless you are very experienced. You can do that. You can say which lobe is involved from seeing an X-ray, but it is better to report the findings in terms of zones rather than reporting in terms of lobes. I think I have made this clear. Am I? Okay. So let's come to the reading of chest X-ray, how it should be read. There are various points through which, or there are various actually methods to read a chest X-ray. A person can decide to read, to go from inside out technique, where you can start from mediastinum and then you can go laterally, explaining the lungs and then soft tissue and then bones and other parts. But this is the most widely practiced method of reading a chest X-ray, where you will see whether it is an inspiratory film or expiratory film. You can see from chest X-ray. Then penetration, how far the penetration has been. Sometimes there will be a problem with the machine, which will the intensity will be lower, so there will be lower penetration, or sometimes it will be higher. Or if a person is thin, suppose even a regular penetration, if that person is exposed to, in that particular person, the penetration, the report, the X-ray, if you see, it will be like or penetrated film. Or position of the patient, then bony skeleton, then position of trachea, diaphragm, and outline of the heart and mediastinum, and then towards the end you need to come to the lung fields. So please remember this, and this is, like I said, most widely used reading technique, and even I'm more confident going from this list rather than reading it from inside out. So we'll discuss one by one and issues related to it, and we'll see a few examples. How we decide whether the film is inspiratory or not. Usually in the good inspiratory film, we will see 9 to 10 posterior rib will be seen. Where they are is, suppose this is a chest X-ray. Now whatever parts, and I'm sure that everyone of us knows that this is a PA view, posterior anterior view. That means the plate will be kept on the chest or in front, and the rays are passed from behind. So these are the ribs, and whatever we see here, these are posterior ends of the ribs. Okay, there are two ends of the ribs. One is posterior end, which is attached to the vertebral column, and the anterior end will be having cartilages and which attaches itself to the sternum. So all these are posterior ends, and these, if you can appreciate here, this is clavicle, and these, if you can appreciate, are anterior ends, and that is the reason you are not seeing it up till mid part where the sternum is located. There is a gap here because there is a costal cartilage, and that is the reason. If you know, for this particular point of exposure, if you want to see, we need to count the number of posterior ends of the rib. So this is actually the third rib, because this is first which will go behind and will have the posterior end. This is second anterior end, it will go behind and form posterior end, and this is third rib's posterior end, fourth rib, fifth, sixth, seventh, eighth, ninth, and 10th. So if you are able to see, suppose 9 to 10 posterior ends of the ribs, then it can be safely said that this is an inspiratory or mid-inspiratory film, which is good enough to do or give any opinion on the chest X-ray. Because if the exposure is not correct, then you may miss many things on chest X-rays, which sometimes it is difficult. And the point more closely related to the same thing is penetration. The thoracic intervertebral disc space should be just visible. So what it means is, if you look at the same X-ray, these are the posterior ends, and like we already counted, 10 posterior ends of the 10 ribs are visible, and these are vertebral bodies, right? This is a spinous process, and these are vertebral bodies, and these are intervertebral disc spaces. And we say the penetration is good if these disc spaces are just visible. So they should not be very clear, and they should not be absent also. So disc spaces should be just visible to say that X-ray penetration is good. So there are 2 points. I hope you will remember these 2 points. Before, these are the things which need to be done before interpreting any of the chest X-ray. Okay. So now, if you can see here, low lung volumes and full inspiration, the difference between the two X-rays of the same person, right? So you may report many things here, but it is because this is low lung volumes, and when this person inhales properly, and then lung volume will become good, and then all the findings we were thinking previously will disappear. So this is just because the person was not or did not inspirate early while X-ray was taken, because here if you count the number of ribs, this is third, 4, 5, 6 and 7, right? This is third, 4th, 5, 6, 7, 8, 9 and 10. So that makes a difference. So here we can safely say that this is full inspiratory film, and here it is an expiratory film in this case. Before you mention any abnormality in this chest X-ray, I think you need to get a re-X-ray done so that it will be easier to report that. And this is how overexposure and underexposure differ. So here you may report many findings, and here can you see these two X-ray, and can you see any of the finding in this X-ray? Okay, this X-ray. Can you give a try? Okay, I think people are thinking. Right hilar node. Okay. This you okay. Right hilum. Okay, I'll come to the hilar structures later on. Then I think it will be more clear for you. But there is something else also in this picture right here. So here there is a small nodule here. You can appreciate in this chest X-ray, but that cannot be appreciated in this chest X-ray, and that is only because the exposure was high in this chest X-ray, and it was a proper exposure in this chest X-ray, and that is how it makes a difference in diagnosis. So you may miss some of the important findings here if the exposure is not good. Okay, so this is the overexposure and the. Can you appreciate anything here in these two? Please have a look at both the X-rays on right side. Can you appreciate any finding in these two? Okay, I'll give you a clue. Right lower zone. Okay, in the interest of time, I'll go ahead. There is a small nodule here in the right lower zone which is seen on the chest X-ray. Okay, which was missed here if the exposure is not good. So let's go to the position of the patient. Medial ends of the clavicle should be equidistant from the spinous processes. So these are the medial ends of the clavicles and these are the spinous process. So to say that X-ray is the position of the patient is central, these medial ends of the clavicle should be equidistant from the spinous process. And if there is any deviation from that, then it is called as rotation, and it will completely change your, it will make your right hilum or make a patient's right hilum more prominent, and it can be wrongly reported as a prominent hilum or any lymph node or anything like that. So that should be, we should be careful in that. Then bony skeleton, symmetry, scoliosis, rib crowding or other things can be seen in the bony skeleton. Here there are various examples you can see in this. Here you can see the scoliosis where there is bending on one side, and in this X-ray you can see some of the rib crowding here. Here there are these rib, the intercostal spaces are okay, and here you can see the closeness of these ribs. This is because of the rib crowding and also because of the damage of the parenchyma and affecting contraction of the pleura, which has pulled the lower this diaphragm upwards, and then also trachea this side and crowding of the ribs. These are the findings of old healed tuberculous fibrosis or collapse, consolidation collapse. And here in this X-ray, this part of the rib is missing, which is because of resorption of ribs. And in this X-ray, you can see a cervical rib. These are the spinous process, and here you can see a cervical rib from the spinous process. So there can be many different bone abnormalities. Then position of the trachea should be always central, but in some situation it is deviated. If you see here dark column, which is about measuring 3 centimeters, it should be central all the time as compared to the spinous process. But sometimes it is deviated to one or the other side. In this X-ray, if you see, it is pushed because of a large maybe pleural effusion or some large tumor, and it has pushed the lower mediastinum to the opposite side, causing deviation of the trachea also. And in this X-ray, which was there previously in the previous slide also, here there is a pull because of fibrosis and damage here, and because of that all the structures have been pulled towards. So trachea should be central, but there can be either push or pull of the trachea because of the pathology which is involved. Then diaphragm shape and position and level should be seen, and costophrenic and cardiophrenic angles should be seen, in which, like we said, diaphragm, the midpoint of the diaphragm should cross or the 6th or 7th rib should cross the midpoint of the diaphragm. Like if you say anterior end, this is anterior end, 1st rib, 2nd rib, 3rd, 4th, 5th, 6th and 7th. Contour should be smooth, and if 6th or 7th rib is crossing on the midpoint of the diaphragm, then level of diaphragm is said to be normal. If it is suppose 8th, 9th, 10th, then it is downwardly pushed, and if it is 3rd, 4th, 5th, then it is supposed to be push upwards or pull upwards. So diaphragm need to be seen. And then outline of heart and mediastinum. If you see this is right border of the heart, and this is the left border of the heart. Then this is left pulmonary artery, or this marking of the left pulmonary artery, and this is right pulmonary artery. And most of the times people get confused in hilar lymph node with this. So we'll see where the lymph node position of the lymph node is, but please remember at this point, and this is the right pulmonary artery and this is left pulmonary artery. or vessels. And this is the marking of aorta. So all these things are normal, should be kept in mind before labeling any abnormality. And this is trachea and two bronchi, right bronchus and left bronchus. There are other cardiac structures which are seen on the lateral X-ray also, like aortic arch, right pulmonary artery, left pulmonary artery, trachea and bronchi. If you see in this, this is trachea or aorta. So this is heart. This is left lateral view of chest X-ray. This is aortic arch. Here you can see the right pulmonary artery, left pulmonary artery, and trachea and bronchi. So in the cardiac structure, the more common thing what we report is cardiomegaly. How it can be done is there is something called as interthoracic diameter or transverse interthoracic diameter between two ends here. And this is one diameter which is taken, and this is another diameter, that is two sides of cardiac shadow. So this shadow, if it is suppose half of this interthoracic diameter, then it is considered as normal sized heart. But if heart size exceeds this half of interthoracic diameter, then it is called as cardiomegaly. So you can safely report cardiomegaly if you see more than half, but other conditions need to be satisfied. Again, central position of the trachea, or there is no rotation, proper exposure, and all those things if they are there, and then you can say that this is cardiomegaly if the thoracic or cardiac shadow is more than half of the transverse thoracic diameter. And towards the end is lung fields. Then this is where we see the abnormalities, upper, middle and lower lung zones. How these zones are divided are from anterior end of second and fourth rib. So anterior end of second and fourth rib, to be specific, upper borders of anterior ends of second and fourth rib. So there is a line or imaginary line which passes through these anterior ends of second rib, anterior ends of fourth rib, and this divides the lung or shadow into three zones. So zone above the line passing through anterior ends of the second ribs is called as upper zone, and line between second and fourth rib is called as lower zone, and line or the zone below the line passing through anterior ends of fourth rib is called as lower zone. So it's something like this: upper zone, middle zone and lower zone. So whatever findings you see in chest X-ray, you report in terms of zones. So if I see any cavity here, I'll report that there is a cavity in the upper zone. So here we don't say lobes. So it is safe to report in zones. It is easier and it is very widely practiced. So approach should be systematic, where we need to see lungs, then pleural surfaces, cardio and mediastinal counters, bones and soft tissues, and abdomen. There are few things which are worth second look. These are apices, retrocardiac areas, hilar regions, and below is diaphragm. This is one chest X-ray. I will not. Okay, because of to save some time, I'll just mention the abnormality here, and then we'll go ahead. Before this, it is difficult to interpret something here, but if you see the apex once again, you will see a shadow here. If you don't see again, you will miss. So that is how it is worth looking again at the apices. This is the same X-ray of apical TB, and this is a mediastinal window of this, where the lesion is seen in the form of small nodule, which could have been easily missed. And this X-ray also, most of the people will miss a finding here. There is one shadow which is overlapping the heart shadow, which is behind the heart shadow here. If you can closely look here, there is a small line, or there is a line which can be seen here. If you see a lateral X-ray of the same thing, you will appreciate better. So this is the heart shadow here, and then you can see another opacity here, which is retrocardiac. So this is retrocardiac opacity, and sometimes if you tilt X-ray a little bit, you can see these double shadows. It is easier This will come with practice. Also, if you see in this X-ray, there is one opacity here behind the diaphragm, which is a nodule behind the diaphragm. You can appreciate a small finding here, which can be also missed if we are not vigilant. So, patterns of disease in which can be reported in chest X-ray can be consolidation or airspace opacity, then interstitial opacity, nodules and masses, lymphadenopathy, cysts and cavities, and pleural abnormalities. So these are the most commonly used patterns of disease which are reported in chest X-rays. I'm sure that you might have seen all these in your practice. So first come first, consolidation, where the most common term which is used is air bronchogram. Please try to understand what it is. It is caused by filling up of the alveoli with fluid, pus, blood, cells, or tumor, etc. It may be diffuse or isolated to segments or lobes of the lungs. May be associated with air bronchograms. Nothing but these are bronchi or smaller bronchioles which will contain obviously air, and the surrounding area will be filled by the opacified lung, because the alveoli should contain air, but now these are containing all these pus, blood, or infected material, and only these bronchi they are containing air. And that is the reason in X-rays will pass through bronchi but do not pass through the surrounding spaces, and then that is how you will see small columns of air which are called as air bronchogram. And sometimes in the normal X-rays, what markings, if what you see on chest X-ray, those are not bronchi. Please remember that those are markings of the vessels which are along with those bronchi. So, and that is the reason you will see those markings on the chest X-ray, even if it is normal. Those shadows are because of vessels which are along with the bronchi. So if you see this chest X-ray, these are the markings. These are the small columns of air you see here, and this is called as air bronchogram, which is seen in consolidation. So it is very typical of consolidation and pneumonia. Now the interstitial opacity, interstitium is nothing but it is, when a disease is localized to pulmonary interstitium, that is alveolar septi, connective tissues, and that support the alveoli, the hallmark is lines and or reticulation. Reticulation is nothing, lines in one direction, reticulation you will see lines in both the directions, which will give a sieve-like appearance. So small well-defined nodules will be seen, which will be called as miliary pattern. In cases of PCP and miliary TB and those diseases which affect the interstitium, the findings will be seen into the, or there will be prominent interstitial spaces. So if you can see all these lines here, these are nothing but interstitium which is filled with the exudative material or the whatever because of PCP or any inflammation. So or miliary TB, like all these things. If you take a closer look of this, you can appreciate in a better way here. If you see some of the lines here, all these are prominent interstitial spaces. Usually the reporting of the X-rays will be prominent bilateral prominent interstitial spaces. Okay. Also here, if you see interstitial opacities, next is nodules and masses. There is a difference between these two. So nodule, we call it as a nodule when it is a discrete pulmonary lesion, sharply defined, nearly circular, opacity 0.2 to 3 centimeter size. If it is more than 3 centimeter size, then it is called as mass. It is described based on its number. It can be a solitary or single nodule, or it can be multiple nodules, or size, smaller or larger. Then borders, maybe uniform border or non-uniform borders, or well-defined or ill-defined borders, and then presence or absence of calcification and location of these nodules and masses. So if you see these X-rays, there is a well-defined this is a well-defined mass. Okay, this is ill-defined here, and I don't know why I'm not able to see this, and here is again mass. Lymphadenopathy, first thing is we should know where the normal lymph nodes are located and what are the normal structures to see. See, it is very courageous to report any X-ray as normal, because that means you have ruled out everything and then you are reporting. Sometimes it is really difficult to say normal. Small findings you can report easily. So non-specific terms like mediastinal widening or hilar prominence is used, or specific term like particular station enlargement, that is hilar or tracheal lymph node or paratracheal lymphadenopathy or any other group of lymph node which is involved. If suppose this is the X-ray, these are the upper mediastinal lymph nodes which are visible here. Which may be visible, and this is usual location for the hilar lymph node. So please don't get confused between this and this. So this is right pulmonary vessel, and this is the position for lymph node or hilar lymph node. So infrahilar window, there is another. If you see the lateral X-ray, there is a small window here in below the hilum, which is sometimes or subcarinal space, which is sometimes gets filled and forming a donut sign. Then left hilar, and this is subcarinal area. So, and this is now very clearly you can see, or you will appreciate the right paratracheal lymph node and bilateral lymphadenopathy. Can you see this? And if you see the closer look of the hilum here, you can very well appreciate the lymph node which is sitting here. There is right hilar lymph nodes. Okay. Okay. And this is a CT scan, again mediastinal window, just closer to the vertebral column. You see a caseous central caseation also. Cysts and cavities, abnormal pulmonary parenchymal spaces or holes filled with air or fluid with a definable wall that is more than 1 millimeter. So cyst is congenital or acquired. It can be congenital or acquired. Cavity, it is caused by tissue necrosis, inflammatory and or neoplastic. There are various characteristics of these based on wall thickness, inner lining, presence or absence of fluid level, and number and location. Just can respond to this whether it is TB or not. Are there radiographic features that suggest benign versus malignant diagnosis? This is a 45-year-old man from India. Why I mention India is because high TB burden country with cough and weight loss. Can you see here any cavity? Okay, here is a thin walled cavity. You can see here. Here is a CT scan picture, again HRCT. And here is another X-ray which is showing this cavity here in the upper lobe, and there is one more picture which cavity with air fluid level. Now please try to differentiate that all these cavities, they are different from one another. If I talk about it more, they differentiate between benign and malignant. Benign cysts are uniform, wall thickness will be 1 millimeter, smooth liner, smooth inner lining, for example in PCP. The benign cavities will be maximum wall thickness will be less than 4 millimeter. So above 4 millimeter it will be called as bulla, and minimally irregular inner lining. And malignant cavities will be wall thickness will be more than 16 millimeter. Irregular linings will be seen. For example, here if you see the inner linings are very irregular. So you can remember this short form to remember the causes of or differential diagnosis of cavity: C for cancer, A for autoimmune venous granulomatosis or any rheumatological diseases, and then vascular malformations or infractions. You can see cavity in it. Then infections like tuberculosis or abscesses, trauma like lacerations, or young patient there are some congenital diseases also which may present as cavity. So this is one acronym which is used for differential diagnosis of cavities. You can remember. So pleural diseases, pleural effusion, that is angle blunting to massive effusions, thickening, mass and air. You can see in the pleural cavity, and then calcification also you can see. This is a concavity upwards, air fluid or the fluid level with concavity upwards, and homogeneous opacity with concavity upwards you can see here in the PA view and the lateral view, and also blunting of the angle you can see on the other sides. So pleural effusion, though it is seen like this, but if you see the lateral X-ray of the same person, it will be like this. Because of the capillary action also, the fluid will be raised here, and that is the reason you will be able to. This is an oblique view where you can see the pleural effusion in a better way. So post-TB calcification, if you want to see, so this is a calcified lymph node which is near to the vertebral column here, and here also you can see one calcification. And this is a thickened pleura, which is usually seen if patient gives history of old treatment of tuberculosis. So please correlate with the old history of treatment of tuberculosis and old treated patients. These are few signs you can see which will rule out the active tuberculosis in some of the patients, and there is no need of treatment as such. So this is thickened pleura, parietal pleura, and also the lymph node, calcified lesion. So these are people characteristic chest radiographic findings in selected patients who are HIV positives with various opportunistic infections and neoplasm. Diffuse and multiple infiltrates, focal infiltrates will be seen in these diseases. You can go through this list later on, because in the interest of time I will not go through these details, but this alveolar pattern can be seen in bacterial Mycobacterium tuberculosis or Cryptococcus neoformans infection initially, and then other diseases, then reticular or granular pattern and miliary pattern. So one finding can have a differential diagnosis like all these things. So all these things, whenever you see cavity, please keep all this Mycobacterium tuberculosis, bacterial infections and fungal infections, and Mycobacterium kansasi or other atypical mycobacteria, pneumocystis. So all these things can be kept in mind. So all these will become your DD when you see that particular finding. Similarly, intrathoracic adenopathies, pleural effusions, and normal chest X-ray. So please remember that pneumocystis carinii, fungal infections, M. tuberculosis, Kaposi sarcoma also may have normal chest X-rays. Of tuberculosis, can this be a TB? So typical pattern of TB is post-primary tuberculosis. Distribution will be apical. Posterior segments of upper lobes will be involved. Superior segments of lower lobes will be involved. Isolated anterior segment, if it is involved, please remember that it can be Mycobacterium avium complex, because it is unusual for Mycobacterium tuberculosis to involve isolated anterior segment. Now for this you will require opinion of radiologist or chest physicians, but otherwise you can just report as upper lobe involvement or these infiltrations and in the epices. Typical pattern of post-primary TB is airspace consolidation, cavitation or endobronchial spread, miliary TB, bronchostenosis, tuberculoma, pleural effusions, or sometimes it can be empyema also, which is called as pus in the pleural space. So, and now this is a typical pattern. Now in TB usually we expect lesions to be in the upper zones, but here you see lesion in the middle and lower zones, which is a typical presentation of tuberculosis. So any lobe can be involved, slight low predominance, airspace consolidation, cavitation is uncommon in severe immunosuppressed, adenopathy is common, and then right side is more commonly involved, like in pediatric cases we discussed before, and then miliary pattern and pleural effusions. Now this also can be TB where there is interstitial involvement, and this is a miliary form of tuberculosis. So there is a difference between this typical and atypical pattern. Infiltration can be typically seen in 85% of post-primary TB, and where in primary TB it can be in upper zone or lower zone also. Then cavitation is common in primary, and where adenopathy are common in primary tuberculosis or severe immunosuppressed patients. And effusion also can be present in both forms of TB. But if we compare early immune suppression with late immune suppression, the patterns will be like this. Early immune suppression, the disease pattern will be like any disease in immunocompetent person, but late immunosuppression will be like like a primary tuberculosis, where you will see lower lobe development, and then adenopathies and pleural effusions more commonly seen, and no cavitation as such. And sometimes X-rays will be absolutely normal, but bacillary load will be really high. And like I said previously, old heel TB, this is one calcified granuloma, which is Ghon's lesion, and these are other hilar lymph nodes which are calcified, and with the hilar calcification it is called as Ranke's complex, and these are apical pleural thickening which is seen, and fibrosis and volume loss in the apex. Some additional X-rays and scenarios before I wrap up the session. These are from again macronodules. Okay, I don't know why I'm not getting those X-rays. This is one case where prior to treatment and 4 weeks after starting antiretroviral treatment, I hope every one of you is aware that starting treatment, if there is deterioration of the chest X-rays, then it is called immune reconstitution inflammatory syndrome. Here you can see or appreciate a small cavity on the left zone after 11 weeks of ART. This is again a sign of immune reconstitution inflammatory syndrome. And this is X-ray of a patient who was admitted with left opacity or homogeneous opacity in left mid zone and lower zone, and which is left heart border, and also inhomogeneous opacity in right mid zone. And you can see on discharge there is a clearance, and this was actually a mixed infection and was having tuberculosis. This was actually a TB culture negative patient. It was a patient of GST under supervision of Dr. Rajshekharan. And this is nocardia. So nocardia should be kept in mind if a person of TB is not responding to your treatment other than TB drug resistance. So this should be kept in use. This is a key which is seen and so please ignore that, but the right lower zone you see an inhomogeneous opacity. So HIV infected patient, CD4 less than 50 and demonstrating focal opacity in the right lung. This is also from macro curriculum, where you can see the chest X-ray shows diffuse reticulonodules in both lungs and right lower zone, usually typically this type of interstitial reticulonodular pattern in PCP. Again, this is right lower lobe consolidation, where you can see here diffuse lung infiltrates or atypical changes including cavitatory disease. So while reporting the X-rays, please report in terms of zones and findings. Don't give diagnosis in reporting, and suggestive of, you can say. So just to wrap up, I'm coming to the end of the presentation. So technical quality can significantly impact chest X-ray interpretation. Please note that you are in doubt that X-ray is not of good quality. Don't hesitate to repeat X-ray. But someone is giving bad X-rays all the time, so it is worthwhile to go to the person and check the technical capacity there in the X-ray room. You get a good quality X-ray institution. Then develop a systematic approach and use it every time you see a chest. Don't just jump to the positive findings. Start from the steps we try to discuss, and that will help you, and it will ensure that you don't miss any abnormality in the chest. Practice identifying normal X-rays or normal X-ray anatomy. So try to appreciate normal things first, and then whenever you some radiologist send you an X-ray with report as a normal, try to discuss or try to focus that more, because if Like I said, it is very courageous to say any X-ray as normal. If you learn to report a normal X-ray, it is easier for you to report an abnormal X-ray. Because to say normal, you will have to screen thoroughly, and you need to know normal anatomy at your best. Then it is important to characterize and describe lesions can help with differential diagnosis. So like I said, jump onto the diagnosis, don't try to make diagnosis on chest X-ray, just give findings, then try to correlate those findings with your differentials and with clinical presentation of patient and other lab parameters to make a definite diagnosis. Then basing a diagnosis of TB on initial X-rays, it may lead to overdiagnosis, which unfortunately is not very uncommon. So it is seen commonly, and it is should be avoided. So all said and done, whether typical or atypical, TB can always fool us. So even if it is normal X-ray, you cannot completely rule out tuberculosis. And even if you are seeing was very typical of TB, it can be something else, or TB can be missed anytime. So please be vigilant on exposure or history and other TB history of contacts, and then past history of tuberculosis or anti-TB drugs consumption. All those things need to be kept in mind before. There was one question I saw whether digital X-rays are helpful. Yes, they are helpful, but again, you will need a practice on reporting digital X-ray, because you see more prominent bronchovascular markings on digital X-rays. So unless you you have that habit of doing digital X-rays, which are more clearer than the conventional X-rays. Sometimes people over-diagnose certain things on digital X-rays, which may not be correct. So there is some difference between the clarity between the conventional X-rays and digital X-rays. Please try to practice more so that can. So these were what I shared with you. They're just basic tips which can be helpful for you sitting at the center when X-ray, when any patient walks in with some X-ray. So try to report yourself first and then look at the report if the patient has. So that is how you will practice it repeatedly, and then this tool will be very helpful in using some of the infections at our center. I hope this will be helpful. Now the questions and feedbacks are welcome, so you can send us emails, or you can give your feedbacks here in the chat box. And I thank you very much, and I apologize for taking a few more minutes. I think I've exceeded my time by 12 minutes, but I appreciate your presence, even though this session was extended for some time. Thank you very much, and see you all in the next NDLS, which will be on the fourth Wednesday of this month. Thank you.
Thank you so much, Dr. Anwar. It was indeed an informative presentation with excellent radiographic examples. Now I request participants to kindly vote. You can see on your left side there is a e-poll. You are requested to kindly vote on that. And if you have any query, you may please write it down in the chat box.